For the next session, I would like to invite our chairperson, Professor Abhijit Chandra, Professor and Head Surgical Gastroenterology, Lucknow. He's having a special interest in advanced GI, laparoscopy, and colorectal surgery. And I would like to also invite Brigadier Retired KJ Singh, Professor KJ Singh. He's a GI and liver transplant surgeon and presently working in Command Hospital as a professor and head. I would like to request our chairperson to invite our speaker for this next session.
So I would like to introduce the speaker, Dr. Supriya Sharma. She was my colleague at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, hepatobiliary and transplant surgeon. And recently, she did with me a survey, which I was referring to in one of the earlier sessions, on the prevalence of bile duct injury in India, which probably was first of its kind in our country. So I now invite Supriya to make her presentation.
A very good afternoon to all present here today for the Jaipur Surgical Festival. I bring greetings from Lucknow. I would like to thank Professor V.K. Kapoor and the organizing team for this opportunity which has been given to me. My brief is to speak about how and when to suspect a bile duct injury after cholecystectomy and what to do then. Well, all surgeons are extremely fastidious, alert, but it is still a fact that 2/3 of all bile duct injuries are only detected post-operatively when the patient presents with either clinical features to suggest an intraperitoneal collection of bile, or later on when they come with features to suggest a biliary stricture. The groups have actually looked at post-cholecystectomy abdominal collections and concluded that counterintuitively, the symptoms caused by bile leak are actually very subtle. Prominent abdominal pain and tenderness develops in only 20% of the people. Hence, there is often a delay in diagnosis and drainage of bile, and if this delay is more than 5 days, it results, unfortunately, in serious outcomes. When we followed up 214 documented cases of bile duct injuries, we found that over a median follow-up of 15 months, 30% actually had normal LFTs, isotope scan, and cholangiograms. And the ones who did have a biliary stricture were more likely to have had a complete bile duct injury, high fistula output, or a fistula which was persisting for more than 4 weeks. What these two studies go to suggest is that a bile duct injury can manifest post-operatively at varying periods of time, immediately after surgery, within a few hours, a few days, weeks, months, to even years down the line. So, how does one suspect a bile duct injury? Well, in the early post-operative period, if a drain has been kept in place and the drain brings out bile, there is no confusion. If there is no drain, then a patient who is clinically unwell, which may be due to a biloma or a biliary ascites or biliary peritonitis, should be suspected to have a bile duct injury and chased accordingly. In the later post-operative period, patient presenting with clinical features to suggest a biliary stricture obviously would have had a bile duct injury at the time of cholecystectomy. Now, one expects after a routine cholecystectomy to see a happy, satisfied patient in the post-operative period. So any patient complaining of abdominal pain, distension, malaise, fever, with tachycardia and tachypnea should raise the red flag. In fact, it would be prudent to counsel every patient at the time of discharge, even after seemingly normal cholecystectomy, to return back to the hospital in case of unwellness. If you're so concerned about bile duct injury, why don't we get routine liver function tests and ultrasounds in every patient before discharge? Well, for one, this would be a huge overkill because minor derangements in LFTs and some collection on an ultrasound after cholecystectomy are commonly seen. Having said that, grossly deranged liver function tests and/or an ultrasound finding of an intra-abdominal collection in an unsettled patient should be suspected to be a biloma unless proved otherwise. So the line of investigations that one follows when suspecting a bile duct injury in the early post-operative period would be to look for evidence of sepsis, intra-abdominal collections, evidence of ongoing bile leak, and presence or absence of ductal continuity. Evaluation of the type and level of bile duct injury and associated vascular injury are not important at this stage unless one is contemplating an early repair. The ubiquitous ultrasound is actually an indispensable tool when attempting to prove or disprove early bile leak, because it will show up a biloma or biliary ascites in the peritoneal cavity. When one sees intraperitoneal fluid correction, and if there's a doubt about the nature of the fluid, one can do an ultrasound guided aspiration then and there to confirm. Ultrasound examination may pick up distal CBD stones, which may have been the cause of the cystic stump blowout. And ultrasound can also serve as a guide to place a percutaneous drainage catheters. However, subjectivity, gaseous dissension due to paralytic areas, and obesity may make ultrasound evaluation inadequate. So, if there is a strong clinical suspicion, one is justified in proceeding with a contrast-enhanced CT scan because it will show a biloma unequivocally and also show up undrained collections which may have been missed on an ultrasound. And if one finds liver perfusion abnormality, it would also go to suggest associated vascular injuries. Isotope hepatobiliary scan, also called the HIDA scan, is a non-invasive and inexpensive investigation, but may not be universally available. But when it is available, it is used to detect ongoing bile leak and show presence of ductal continuity, which is very important to decide regarding therapeutic endoscopic drainage. Now, these are HIDA images obtained in a patient who has had a bile duct injury. One can clearly appreciate extrabiliary accumulation of the radiotracer activity. And in delayed films, one can see radiotracer activity in both the paracolic gutters, suggesting that this patient probably needs more than one drain to attain control of the sepsis. These are HIDA images which show radiotracer activity in the drain which has been placed intraoperatively. In the delayed images, there is radiotracer activity in the drain and some radiotracer activity in the small bowel loops as well, suggesting that there is continuity of the biliary, some maintained continuity of the extrahepatic biliary apparatus. Besides these two areas, there is no radiotracer activity anywhere else in the peritoneal cavity, suggesting that this is a controlled external biliary fistula with maintained ductal continuity. So a HIDA scan is very useful to detect ongoing bile leak and show ductal continuity, but it may be poor in showing anatomical localization for exact demonstration of the site of leak. And sometimes it gives a false negative result with regard to ductal continuity when there's a major leak and the bile with the radiotracer preferentially flows out through the leak into the drain rather than through the collapsed distal duct. Fistulogram through a drain which has been kept in situ is obtained sometimes when one doesn't have access to more advanced facilities. It just requires contrast and an X-ray machine. It is good when it shows up things which help one to make a decision. For example, if it shows up all the intrahepatic biliary radicals and it shows up the distal duct, it's a good investigation. But many a times, the contrast when injected through the drain will just spill all over and not give an adequate examination. So other forms of cholangiography are preferred. MR is an excellent tool because it will show the biloma and ductal continuity or discontinuity and can be combined with an angiogram to obtain vascular status. But presence of a large biloma near the hilum, metal clips, ascites would interpret MR evaluation. So one has to time the MR study to the time that the MR has been, to the time the biloma has been completely drained. ERC in early bile duct injury, excellent tool to confirm a bile leak. It identifies the site of bile leak. If there are associated distal CBD stone, one can use that opportunity to clear the CBD stone and also do endoscopic stenting and nasobiliary drainage depending upon the treating physician's preference. So a diagnostic ERCP in bile duct injury has a significant role to play. However, it will fail to show up isolated sectoral or segmental injury when that particular duct is separated from the main ductal system. What about PTBD? Now, it is Difficult because the ducts are collapsed, so it is not routinely resorted to. Only when there is a large volume external biliary fistula due to complete transection and no possibility of an ERC drainage to control the ongoing bile leak, then one might resort to a percutaneous biliary drainage. That too, if one has the skilled manpower to accomplish this. Many patients will slip through this early period and present only months to maybe even years later with features of a biliary stricture like jaundice and recurrent episodes of cholangitis, sometimes sepsis due to multiple cholangitic abscesses. Isolated structural injury are generally asymptomatic and picked up only on an ultrasound or a cross-sectional imaging done for some other reason. Some of them may also present with cholangitic abscesses. So, while investigating a patient with biliary stricture, exclude sepsis, look for liver dysfunction. Transaminitis may be seen in cholangitis, and coagulopathy may be seen when there is liver dysfunction from secondary biliary cirrhosis. One has to delineate the type of stricture, evaluate for atrophy, hypertrophy, and also detect associated vascular injuries. Ultrasound in an established biliary stricture is a good tool to show the biliary radical dilatation and give some idea of the level of biliary stricture. It will pick up intrahepatic stones if present. Coarse liver ecotexture if seen may suggest development of secondary biliary cirrhosis, but of course one needs to confirm this with other tests. It will show atrophy, hypertrophy of either of the lobes, cholangitic abscesses, and splenomegaly or collaterals, which would suggest portal hypertension. A CT scan in a biliary stricture is not routinely done unless one suspects malignancy to be the cause of the biliary stricture. Sometimes one may obtain a CT scan in a biliary stricture for medical legal purposes to demonstrate vascular patency and prognosticate outcome of stricture repair. ERC is not routinely used in a biliary stricture as an investigative modality because it may not pick up, it may not demonstrate any presence of a complete stricture of the proximal ducts, and it does not show isolated sectoral strictures. Besides, contrast into undrained obstructed systems may introduce infection and precipitate cholangitis. Upper GI endoscopy is done only when patients present more than 6 months after a bile duct injury to look for varices secondary to portal hypertension. Presence of portal hypertension by itself does not alter management, but may suggest need to refer to a tertiary center. Liver biopsy is not done routinely, only when one needs to document secondary biliary cirrhosis, when there is gross liver dysfunction or failure, and liver transplant is being considered as the treatment option. MRCP is the cholangiography method of choice because it is non-invasive, shows all the intrahepatic ducts, even the isolated ducts, helps to classify stricture according to Bismuth classification, and be combined with an arteriography or portography to evaluate vascular injuries. These are just MRCP pictures to show a type 1 stricture, a type 2 stricture, a type 3 stricture, a type 4 stricture, and a type 5 stricture. But no investigation is foolproof. For example, in this particular MRCP image, one gets the impression this is a high type 4 stricture with 4 ducts present at the hilum. So when we obtained a pressure injection via a PTC catheter, we realized that actually the confluence is patent, and this was a false high MRCP image. Sometimes, like in this particular case, one gets the impression that this is at least a type 2 biliary stricture. But on rotating these images, one realizes that this apparent impression was because of overlap of the right anterior sectoral duct with the right posterior sectoral duct. So if I have to encapsulate, the aim of investigation in bile duct injuries, at least in early injuries with collection, is to delineate all intra-abdominal collections and ensure that they have been drained completely. And further investigations are dictated by the availability of local therapeutic options, which would determine whether one needs to proceed further or refer the patient to a tertiary center. When bile duct injuries present later with biliary stricture, one needs to rule out malignant stricture if it is indicated on the basis of history or histology, establish the Bismuth type of biliary stricture, and look for features of portal hypertension and cirrhosis if the injury is more than 6 months. We conducted an online survey to look at the prevalence of bile duct injury during laparoscopic cholecystectomy among Indian surgeons. And what we found was 86 of our respondents had actually had an experience with bile duct injury during laparoscopic cholecystectomy, and 78% had had more than one bile duct injury. So I would like to conclude by stating that maintain a high index of suspicion of a bile duct injury, whatever may be your personal laparoscopic experience. No surgeon is exempt from a bile duct injury during his surgical career. Preliminary investigations when an acute bile duct injury is diagnosed or suspected are to diagnose, confirm, and ensure complete drainage of all intraperitoneal connection. And in established structure, the investigations are tailored to understand the appropriateness of surgical repair at that center. Difficulties in surgical repair would be governed or would be rather be determined by the technical difficulties, local facilities, and surgeon experience. Thank you.
A very comprehensive take on the topic, and we'll be discussing various aspects through the day, ma'am. So before I ask, is there somebody, do we have any? Somebody asking some query? Okay, so I can start the thing. A couple of questions, ma'am. So in a kind of a wet scenario where there's an ongoing collection or a fistula, one thing is sometimes it's important to tell the younger surgeons that a drain may not always reveal the thing. There may be more collections, and you can't just because the drain is dry, patient is unwell. The clinical situation is very important. The drain may be dry, may be improperly placed, it may be blocked by the omentum, and it may be kinked inside if not properly placed. So that is very important. Second, you went through the entire gamut of investigation, but in a wet system, what would you prefer to do after an ultrasound and the patient has been stabilized? The collections have been drained. So between a CT, MRI, HIDA, in a place where everything is available, what would be, because if it's a cystic duct stump blowout and the ultrasound is not picking up the continuity because of gas, obesity or whatever, then maybe the MR and then followed by the ERCP. So how do you advise a young person with a fair amount of facility available to go about this situation?
Yeah, thank you, sir. So I don't expect HIDA scans to be available at all institutes. And even now at our center itself, with the widespread availability of MR and the experience and the comfort level that we have with MR films, after drainage of any intra-abdominal connection, and if we are contemplating an intervention beyond that, then an MR would be the investigation of choice that most of us would resort to as well. HIDA was being done previously, but now it is not routinely being done. So,
as you rightly said, anatomically also it's not very accurate. So
absolutely, and anatomically also it is not very accurate. And again, MR as a technology keeps on evolving. What I say today, tomorrow changes. Depending upon what all we can get out of an MR study. So after an ultrasound drainage, if you are prepared to go in further, then MR would be the investigation of choice. Second step, unless the patient continues to be septic and one thinks that maybe the drainage that we have put into place either post-operatively or intraoperatively is inadequate, as in the patient continues to be septic, one expects there are undrained foci of connection, then a CT scan would be the first investigation.
The other query I have is you mentioned that if available, an MRA and an MR photography should be done. So there are enough evidence also to suggest that it really does not make a difference. As it is, you are going very high up. Even if it's a bismuth type 1, you would like to go high up where the vascularity is good. And the left artery, you're extending it onto the left duct. So should it be done? Does it make a difference? Should we routinely do it before surgery if available? It is for the expert audience also. What does the literature say? Does it make a difference? Does it actually change the outcome? It is good. Is it good for prognostication also?
So I know there are speakers who will be delving on this in detail. So, but just because it's a racist question, demonstration of vascular injury is not the primary aim of your first line of investigation. If one is obtaining an MRCP to look for ductal continuity, then MRCP alone is the study of choice. If one has facilities and one is contemplating an early repair, then an angiogram becomes mandatory. Otherwise, an angiogram study is not required as part of the investigative protocol for a bile duct injury. I mentioned these two to complete the list of investigations which are given. But yes, early bile duct injury, because presence of vascular injury when you diagnose it upfront may have a bearing on your decision to proceed with early repair of this particular patient. If it's an already established injury in a benign biliary setting, one presence or absence of at least an arterial injury, if it has occurred at some point during the time of cholecystectomy, will not change the course of your choice of surgical therapy at this point of time when you operate for an established biliary stricture. Portal venous injury would anyway manifest itself in the form of either collaterals, if it is a main portal vein injury, or if it is one of the branches, as in the right portal vein injury, it would already manifest itself by that time in form of one lobar atrophy or the other. That anyway tells you that it is a complicated biliary repair that you're anyways going to undertake, and you have to decide whether you have the wherewithal to go ahead with a repair in this particular situation or not. So I mentioned MR vascular. And another thing, when actively chased with either a cross-sectional contrast in a CT scan or MR, incidence of vascular injuries can go up to 25%. So that is also there. But we have realized over a period of time that whether it happens or not, there are several other factors which come into play in deciding whether you're going to operate right away or you're going to send it away, and in the outcomes of repair. So one doesn't really chase it unless it is indicated for some other purpose. Dr. Vishal,
Supriya, there's some question from Vishal.
Yeah, he stated that angiogram might be important from medical legal point of view, which is a point I put up in my slides as well. Again, one can go on debating about this, because even with the presence of hepatic artery injury, it is not that all biliary strictures will stenose over a period of time. Similarly,
Supriya, for this, what is your protocol that you follow at SGPGI? Do you get an angiogram before repairing, before doing a hepatocytostomy always? Yes or no?
No, we don't get.
No, so we have an answer that institute does not do it. So it does not have that much of implication on following it, that you don't need to do always an arterial anatomy reconstruction always. I think that's the message that you want to give. Okay, but since you have got a point in between about the early repair, so just want to ask you one scenario. Patient has come to you day 2 following a lap chole, having around 200 ml of bile in the drain, and you got a sonography done which is showing some small collection. Day 2, you would like to go in and do a repair hepatocytostomy? First question, yes or no?
No, I would first like to know where this bile is coming
from.
Day
fine,
2,
fine.
20 cc. Okay.
Day 2, 200 cc. So you will not like to go in. Okay, is suppose now my query was because up to 72 hours the present recommendation says that you can go in and do a hepatocytostomy if it comes early. So my query was, will you, if you want to do see anatomy at this point in time with the biloma collection inside, what is the best investigation? Of course, HIDA is not a good investigation, it will just show a leak. MR is not a good investigation with the collection inside. CT is not a good investigation, it will not show biliary anatomy. Fistulogram will not show because there is already a biloma collection inside. So it's true now.
So when a patient comes to me on the second post-operatively with bile in the drain, I would not be looking at early repair unless I know clear cut and I've had clear communication from the surgeon as to what he thinks has gone wrong. Because one thing to understand is if a patient has come to you outside with a bile duct injury, it has been a problem. That's why that injury has occurred in the first place. So I am not very enthused by the idea of early bile duct injury repairs when a patient comes to you with a fistula for a surgery which has been done outside. A clipped bile duct is a different scenario. We're not talking about that. We're talking about a bile leak. So 48 hours down the line, second post-operative, the patient comes to me. I think my thought process is very clear. It is drained, make the patient sepsis free, send him home and deal with the established biliary stricture later on. Unless there is reason to suspect, either on the basis of the preoperative imaging that he has, that this could be because of CBD stones, because of which the cystic duct sample is blown out, which is one can investigate further and do whatever is required to clear this, to clear the bile duct.
Points well taken, Supriya. Yeah, I just want to know from the audience if somebody has some other opinion for an early bile duct injury which has come very early with a drain in situ showing a bile, because we have been having this discussion since morning that for early bile duct repair with a controlled fistula, not for a clipped bile duct, but for a controlled fistula. Anyone in the audience or in the... Yes, sir.
Can I come in?
Yes, sir, please.
Yeah. So what scenario you gave in, if the drain is showing a bile and still there is a bilioma, that means that bilioma is not connected with this drainage. In that case, you will use the USG guided drainage of that bilioma first, because that could be a source of sepsis, continued sepsis. You drain it out. And after that only you will go for what Supriya is saying, that do the MRCP, because by the time then you will assess the type of injury you are dealing with.
I think I would agree with sir. Maybe if this satisfies both the groups, the one who does a early bile duct repair, they would get a PCD done. And once a biloma is drained, actually the message to the all beginners is, once the biloma is drained, you have ample investigations like MR or a fistulogram can be done now. And then subsequently you can do a repair in the same sitting within, if it is to be done next day, if the patient is not in sepsis. Or with the same thing, you can wait for a longer period of time, maybe for 6 weeks as usual, to do a definitive hepatogenostomy.
I will agree with Supriya on this issue to delay the repair in such situation, because when there is active bile leak going on, and there will always be inflammation in that area. And even if you do successfully bilioantaganostomosis, chances of postoperative leak will be higher and stricture formation will be higher. So I will go in such a scenario for delayed repair.
Sir, I think Dr. Chaube has something. Can somebody pass mic to Dr. Chaube, sir, please? Dr. Supriya, by the time he gets a mic, the sir gets a mic, I just want to add one comment to your MRCP images that you have shown. I think now we are very happy seeing a MR video and a rotational film on that. So that makes a 3D image impression given, so that you can see clearly identify the anatomy. And same thing with PTBD also. Once you do a PTBD gram, the rotational films gives you a better anatomical delineation of all the ducts that you are seeing for hepatogenostomy.
Absolutely correct. In fact, that is exactly what I wanted to say when I showed those false high and false low images on MRCP. One has to rotate the images, look at it from all dimensions before one conclusively decides the level of biliary restriction.
One last question from Dr. Chaube, sir. Yes, your voice is enough, sir.
I think my take on the question by Ajay, that patient has come to you within 22 hours, has been referred to you within 72 hours, and you do the ultrasound and you find that the brain is showing the leak and there is a bilioma, and that is why you are in doubt whether it is a complete injury or not. So you drain the bilioma and do the test, taking advantage of that 72 hours period, do an MRCP, and if it shows a complete cutoff, there's a complete transaction, I will go for the immediate repair, because it's no fun, it's very unlikely to heal, that fistula to heal. And that patient, no patient remains satisfied, particularly in Indian setting, with the drain hanging and that bile coming and the complete transaction is very unlikely that it will heal. Expectant management is.
This will have an answer, as sir said in the morning also. I think let more data come on it. We are a proponent of an early hepatogenostomy. So I think let the data come on it with that there is no more stricture rate and there is good long-term follow-up, and then we can other people can follow it. So
Yes, I think
we are very strong proponents of doing early hepatogenostomy.
Case-to-case basis, stability of the patient, institutional practice, experience of the surgeon and the team,
Because
all that should decide.
If you have drained a sting, and that bilioma you have drained, and your radiological investigation do not so take advantage of that. The sepsis will not set in. You have already drained that things. But if you leave the patient, there are more chances that the collection will go here and there because that drain may not
Or
function
sometimes they carry on with the drain for many months.
months.
And then you have to, in any case, operate after many months
Yeah.
on a wet
Yeah.
system with a controlled flush. Thank you, sir. What a lovely debate on this subject. Very lucid presentation, Dr. Supriya. Thank you. We'll close this session here.
Thank you, Chairperson and speakers. Now.